Hi everyone, my name is Meagan Krogmeier and welcome to this presentation for HAP780 at George Mason University. This is an analysis of data mining models for COVID-19 related deaths among minorities. The sections I will be covering include a description of the task, data selection, data pre-processing, the data mining methods and application of those methods, an analysis of the results, and a brief conclusion. Our lives as we know them have been completely changed by the COVID-19 pandemic. On April 5, 2020, COVID-19 was added to the nationally notifiable condition list. I requested and was granted access to the dataset titled COVID-19 Case Surveillance Restricted Access Detailed Data. The dataset is created using CDC's Policy on Public Health Research and non-research data management and access, and include protections designed to protect individual privacy. There are a few challenges with this dataset. First, COVID-19 can cause mild illness and symptoms might not appear immediately. This can lead to delays in testing and reporting. Along with this, not every infected person will get tested or even seek medical care, especially if symptoms are not present. In many states, the public health supply chain issue has challenged hospitals, healthcare providers, and laboratories in reporting complete demographic information, such as race and ethnicity. The volume of cases has also made it challenging for state, local, and territorial health departments to conduct thorough investigations. As a result, some COVID-19 case notifications do not have complete information, even as health departments continue to make improvements through methods such as automated data flows. So what is considered a COVID-related death? Provisional COVID-19 death counts from the National Center of Health Statistics are updated with information from death certificates. This offers the most accurate death counts, but there is a reporting lag time of 1 to 2 weeks on average. Death counts are continually updated as new death certificate data are received. For these reasons, provisional COVID-19 death counts might differ from those on other published sources. In 2020, racial and ethnic disparities in COVID-19 age-adjusted death rates were reported among U.S. residents. Early in the pandemic, Hispanic, AIAN, and Black people had higher rates of COVID-19 cases compared to their white counterparts. The interest for this presentation is in minority disparities for COVID-related deaths, using details such as age of patient, gender of patient, if the patient is symptomatic, and if they have any underlying conditions. Will a generic model built on all COVID cases have a bias against minorities? The data of over 83 million records shared with the CDC as of July 2022 is available in 15 parts. 5 parts were randomly selected with 25.8 million records that needed to be processed and cleaned, as a majority of the responses on the case report forms were listed as unknown or missing. There were 33 attributes in the data, but the attributes that were used to design the models are as following from the data dictionary. First, any rows of data that were reported as probable cases were removed to keep the data consistent with lab-confirmed COVID cases only. Any unnecessary demographic attributes such as age, county of residence, state of residence, date of symptom, and date of positive specimen collection were removed. The last few attributes removed were some symptom attributes that were mostly unknown or missing values, such as reporting for abdominal pain, receiving mechanical ventilation or intubation, acute respiratory distress syndrome, abnormal chest x-rays, and pneumonia. Of the 22 lab-confirmed cases, only about 230,000 cases had complete details of the symptoms, gender, and underlying medical conditions. After this, another 16,000 records were removed that had a value of race as NA, missing, or unknown. With a total of 214,000 patients left with complete data, 176,000 patients were listed with a race of white, and 38,000 patients had a race of American Indian / Alaska Native, Asian, Black, multiple / other, or Native Hawaiian/other Pacific Islander. After pre-processing the data, only 3,738 patients out of the 214,000 had reported a death as a result of COVID-19. To build and compare models, training and testing datasets are used. A training set and testing set were created both from the data with all races and from the data with only minority races. For documentation purposes, the datasets used will be referred to as the following: AR train, which is 80% of the dataset with all races; AR test, 20% of the dataset with all races; minor train, 80% of the dataset of only minority races; and minor test, 20% of dataset with only minority races. Classification analysis will be used because the elements contain class labels, specifically logistic regression algorithms, to compute binary predictions with multiple independent variables. Model A is created by logistic regression on AR train. This model is then applied to the two test sets, AR test and minor test. Model B is created using logistic regression as well, but on the minor train. Model B is then tested with minor test. If Model B performs better than Model A on minor test data, there is clearly an observed bias. Since the data appears to be imbalanced with the number of deaths, Model C is created by resampling AR train with bias to uniform class as 1 with the class equal to race and running logistic regression. This will give copies of the same patients and see if they are underrepresented in the dataset. At classification threshold of 0.5, Models A confusion matrix actually classified all patients as alive. When plotting the ROC with the imbalanced dataset, we see that the rate of positives is very high and the rate of negatives is very low. At default classification threshold of 0.5 again, Model B's confusion matrix is slightly better and actually classified 5 patients as dead. The AUC is a little more than Model A and the ROC looks slightly better as the slope is steeper at the beginning. Applying these models to the test sets gives us the following results. Model A on AR test has an ROC of 0.9263. Model A on minor test actually gives a slightly lower ROC of 0.9187. Model B on minor test dataset has an ROC of 0.9163, which is about the same as Model A on the same test set. The best performance is actually seen from Model A on AR test with ROC of 0.9263. With this data, it is not clear if the slightly lower AUC from Model B is because there are fewer cases or more difficult cases. At default classification threshold of 0.5, Model C performs very similarly to Model A. Finally, we can run Model C on AR test set and minor test set and see that we get an ROC of 0.925 and 0.9183 respectively. In conclusion, Model C with resampled data performs approximately the same as Model A on the test sets, which means there isn't necessarily classifying incorrectly due to sample size, but more likely the cases are harder to predict. Thank you for viewing my presentation.